Welcome all of you for this webinar on from the CPOEM Foundation. And CPOEM, as all of you know, stands for Creative Portal for Oncology Education and more. And today we have an interesting webinar on paradigm shift in the management of advanced hepatobiliary cancer and hepatocellular cancer. And we have a very eminent speaker with us, Dr. Milind Javle, who's a professor of GI Oncology from the MD Anderson Cancer Center in Houston. And following that, we will also be having a case capsule, which will be presented by three of our postgraduates, which will be three different cases, one on advanced hepatocellular carcinoma, and then one on advanced cholangiocarcinoma, and the other one would be on advanced gallbladder cancer. Dr. Javle will be giving his talk on advanced hepatobiliary cancer and hepatocellular cancer, shifting gears from chemotherapy to targeted therapy and immunotherapy. Now, thank our sponsors for the educational grant from Fresenius Kabi, Reliance Life Sciences, and also Cipla Oncology. Just to introduce Dr. Javle, he's a professor in the Department of GI Medical Oncology at the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. And he had his initial medical education at Grant Medical College in India. And following that, he did his residency in the United States and also fellowship in the United States. And he has over 100 international peer-reviewed publications. And without any further ado, I request you, Dr. Javle, to give your talk.
Thanks so much, Santosh and Vishwanath, for inviting me to this very interesting seminar. I'm really glad that you sought me out at ASCO and this could happen. So this is a very important field, and I'm glad that you've talked about paradigm shift, because I've been treating these cancers now for, I want to say, over 15 years. And in the past, there was very little we could do, certainly for HCC, for cholangio as well. I mean, all we had were gemcitabine and 5FU. And so much has changed, particularly in the last 5 years. People are living a lot longer than I ever anticipated. So I'm going to have a first few minutes on HCC, and then we'll talk about biliary tract cancer. So I'm going to talk about HCC first. I mean, these are risk factors. In the US, I don't think it's that different in India. India is not a country with endemic Hep B, like East Asia, or endemic Hep C, like, for instance, Egypt. Unfortunately, with the lifestyle changes in the West and increasingly in our own country, we have a high amount of non-alcoholic fatty liver disease. And this accounts for now 37% of HCC in the US. The other portions are Hep C. Hep C is largely a disease related to sexually transmitted diseases, as well as IV drug abuse. And then you have Hep B, a smaller number, mostly in Asians. About 10% of the Asian population in the US have endemic Hep B, that is vertical transmission. And then a variety of other causes, that is diabetes, obesity. So it's largely a lifestyle disease. So I have several patients, and in fact friends, who have some of them been diagnosed with fatty liver. And I try to assure them that and warn them that fatty liver and NASH is not a benign disease, and we need to act on it now. So this is the lay of the land as it used to be back in 2021. And so much has changed. First line, we had sorafenib, the only treatment now for 10 years, for almost 2 decades actually. And then we have lenvatinib, a much better tolerated multi-targeted tyrosine kinase inhibitor, bevacizumab and atezo, approved last year. And then a variety of small molecule TKIs in the second line setting. You have regorafenib, cabozantinib, ramucirumab for high AFP over 400, and then immunotherapies, that is pembrolizumab, nivolumab, and ipilimumab, and nivolumab. So nivolumab single agent, I want to point out, was approved on the basis of an accelerated approval. This was an accelerated approval based on 100 patient second line study, and a promising response rate of about little less than 20%. These accelerated approvals are based on a contingent to a confirmatory phase 3 study. The phase 3 study, unfortunately, was negative. So nivolumab approval was rescinded. The same happened with pembrolizumab, approved on a second line study. In a one phase 3 study from the US was negative, but as you know, a recent phase 3 study from China was positive. So the pembrolizumab approval has continued in the second line space. This has changed now, in fact, this year with, with two other studies. So you have the Embrave study with atezo-bev, PFS of 6.8 months, a response rate of 30%, an overall survival of 19 months, which is quite stunning, really, for HCC, duration of response for 18.1 months. The Himalaya study, presented by my friend from Dr. Kasana Wolfa with Tremi and Durva. So a shorter PFS, or somewhat lower overall response rate, but a good survival, an overall survival of 16 months, duration of response of 22 months. So although the responses were few, these are long-term responses. And then the cosmic data presented last year at ESMO with Cabo and Atezo showed similar findings, almost as similar to the Embrave data with 6.8 PFS, but a lower response rate, a good overall survival and duration of response. So these are sort of now in the US, the Himalaya study is not yet approved, but it will be. Tremi is yet to get approved. There's single agent data on Durva, which I'm not going to present now, which also looks promising. So I'm just going to put this table together in terms of first line. Where are we now, and how do we approach these data points? So I'm again referring to advanced HCC, for which you will consider systemic therapy, and you would consider really the two practical choices at this time are lenvatinib and atezo-bev. So I don't know how the situation is in India is whether you folks use sorafenib or lenvatinib. In our practice, we have largely switched to lenvatinib because it's much more tolerable, particularly for patients who have some sort of contraindication for IO. Then we would consider lenvatinib. It also has VEGF activity, but less than BEV. So if there's stronger risk of when we do an endoscopy and we find varices, then we're going to avoid it. Tezo-bev, you can think of a small molecule inhibitor. But I think with the approval of the STRIDE regimen is the Himalaya study with one dose of Tremi and continued Durva. I think that's where we're going to use it. For patients who have varices, cirrhosis, risk of bleeding, we're going to consider Durva Tremi instead of atezo-bev. Perhaps if there are some contraindications for combinations, this is controversial, we'll think of Durva. And then Cabo and Atezo, these are approved agents. This is possibly an alternative to atezo-bev in the first line for some reason if you want to consider an option. But this is sort of how I've rationalized how we're going to use these multiple regimens. And fortunately, there is a choice to all of these. Now, in the second line space, there's a variety of agents approved. So there's regorafenib, there's ramucirumab, cabozantinib, and there's immune checkpoint inhibitors, that is pembro and ipi and nivo. These are approved in the second line setting. So, of course, these agents, the rami, regorafenib, cabozantinib, were approved after sorafenib, first line. We have largely extrapolated it now to after lenvatinib, and certainly after IO, like after atezo and bev, we can consider these agents. You may ask, what is the advantage of giving these agents? Because they're really VEGF directed after giving atezo and bev. Well, the answer is we don't really know. But I think with experience, you can find some patients with these agents do seems to stabilize the situation and can be considered. Now, in terms of immune checkpoint inhibitors, that is pembro and ipi and nivo, I don't really see a role for using these agents after atezo-bev or after the Himalaya study. We're probably going to consider them for patients who have received prior lenvatinib. And I'm going to dive in a little deep now to talk about the effect of who are the patients who you would consider lenvatinib for. So you may have seen this article in Science earlier this year, which looked at NASH-related HCC and the effect of PD-1 blockade. So you might have seen in your practice that there are some patients who don't really respond to immune therapy for HCC. And in fact, they have hyperprogression, or if not hyperprogression, there's progression. One hypothesis is these are some of these patients have NASH. So we know that in NASH, there's a progressive accumulation of exhausted CD8, PD1 T cells, and in preclinical models. So this is an interesting study where it's a mouse model of NASH, and in this mouse model does develop HCC. Now, when this mouse model was treated with concurrently with PD1 inhibitor in the status at the time of NASH, not necessarily after developing tumor. So this is not what you would see in real life, but you do when this model was treated with PD1 inhibitors, it actually exaggerated tumor progression and tumor growth. So the figures that you see on the right, there is the this is the control, and this is with the PD1 mouse on the right. You see more tumor cells, more HCC in the face of PD1 blockade in this mouse model with NASH. So this has sort of led to the hypothesis that perhaps patients with NASH may have a little lower benefit, or perhaps not at all, from PD1 blockade. And this is actually in the same study in Nature. They did a meta-analysis of of the three major studies here: Checkmate 458, Embrave, and the Keynote trials. So with Pembro, with Atezo-Bev, and with Nivo. And if you can see in terms of what favors immunotherapy and what doesn't, you see that those who have viral-induced HCC, which is the lower box, it actually favors immunotherapy, whereas those who do not have viral HCC or NASH-related HCC, there was really no benefit. It seems to be close to the center. And it's also reflected on the Kaplan-Meier survival curve on the right, where the non-alcoholic fatty liver disease is the blue line with the lower survival with PD1 blockade, as considered with hepatitis or viral-related HCC. So these data are somewhat provocative, and you might say that, look, we can't say for sure that that non-alcoholic fatty liver disease or NASH doesn't respond to PD1 blockade. But I think certainly if I see a patient in my practice who has obvious fatty liver, who has, diagnosed with NASH, which of course you require an MRI to diagnose it, then I do think sometimes before giving Atezo-Bev, I sometimes prefer lenvatinib, knowing that they can get immunotherapy in the second line setting. So these are some observations and perhaps how we could use this sort of translational data in clinical practice. But this is not the only mechanism of resistance, of course, to immune checkpoint blockade. The other resistance mechanisms include MAP kinase signaling, the Wnt pathway, CDK4/6 signaling, pathways activated after PTEN loss. These are some of pathways associated with resistance to checkpoint inhibitors. Now, one question that I face in the clinic is, now that we use immune therapy in the first line setting, what is the consideration for immune therapy in the second line setting for HCC? Now, if there's primary resistance does occur to checkpoint inhibitors, then in that case, we're probably considering combinations such as CTLA4, that is the P and Nivo, LAG3, TIM3 combinations. I have to point out that some of these combinations, none of them have been terribly successful so far, but in future, we will also consider targeted therapies, chemotherapy combinations, microbiome and immune modifiers in combination with checkpoints. And so this is in terms of primary resistance to checkpoint inhibitors. In terms of acquired resistance, so patients who do get immune checkpoint inhibitors and then get resistant 6 to 8 months later, the mechanistic understanding of the acquired resistance is rather poor. And but in practice, if the patient has received prior IO, there is no data to suggest efficacy with another IO in the second line setting. So I don't personally prescribe it. I think we'll only learn if we do longitudinal tumor and biosampling. So I recommend molecular analysis, immune analysis. So it's not standard at this point to order molecular analysis, but we are learning more. So we are certainly investigating it routinely. Microbiome. These are things that you would check before, on, and after progression. Now, I'm going to touch on a couple of new points, a couple of additional points before I move on to biliary cancer. One is that how do we incorporate this immune therapy in the multidisciplinary management of HCC? So how can we consider this for neoadjuvant therapy, consider this for adjuvant therapy in combination with TACE, in combination with radiation therapy? I'm just going to show you a few snapshots. One is that one is in terms of neoadjuvant, there is a good body of data to suggest that surgical resection has an immune suppressive effect. And the exact mechanism is not clearly understood, but it is believed that with it is believed that secondary to surgical resection, you have a decrease in the interferon gamma signature, a decrease in IL-2, IL-12, leads to sort of an immunosuppressed stroma. And this has led to the consideration of neoadjuvant therapy because you have a high neoantigen burden, you have an intact local regional immune environment, including the tumor and lymph node drainage system. And there's certainly preclinical evidence, which I won't go into great depth, about neoadjuvant versus adjuvant. There's some data in glioblastoma about neoadjuvant therapy versus adjuvant. So this is sort of rationale that led to consideration for neoadjuvant therapy in HCC. So this is a study conducted in our institution, a second line study led by a colleague of mine, Dr. Kassab, where he treated patients neoadjuvantly with either Nivo or Nivo plus IPI preoperatively, and then continued the same sequence postoperatively. And in a small study that you have here, it was quite striking that 5 out of 20 patients, a small number, but a quarter of them had complete pathological necrosis. So you see the radiology over here, the CT scan before and after, which shows these sort of holes, of necrotic tissue, which are biopsied, where on post-hepatic resection received complete necrotic tissue. And then there was, in terms of analysis of blood and tumor, certainly there was a very interesting alteration in immune microenvironment with CDK, CD3, CD8, and CD45 upregulation in the resected tumor. There's a similar study done at Hopkins.
We treated patients with HCC that included patients outside of traditional criteria for upfront resection.
I'm sorry, I'm going to go forward. So this was a study done by
this slide summarizes the clinical outcomes of our
colleague
study.
from
of the 15 patients who were enrolled,
Hopkins, who showed similar findings with Cabo and IPI, with Cabo and nivolumab. So those were data for neoadjuvant therapy with one from our institution, and the second study was from Hopkins, which showed sort of similar findings that neoadjuvant therapy is feasible. I'm going to jump quickly into 2 abstracts presented at this ASCO, one with IO with TACE and another with IO with SBRT. And of course, this is not novel. ImmuTACE is a study from Germany. We believe that TACE releases an immune neoantigen burden, and then that can be targeted with immune checkpoint inhibitor study ongoing in Germany, the ImmuTACE study with TACE and Nivo. 59 patients, they get TACE, Nivo, and then they get another TACE 8 weeks later. Primary endpoint is overall response rate. They find this regimen is quite well tolerated with complete response in 16%, partial response in 55%. And then high pretreatment ratio of Treg to CD8 was present in all patients who had CRs. So ostensibly, there was modulation of the immune microenvironment in those patients who had CR as compared with those who didn't. Median progression-free survival of 7.2 months. So sort of a provocative information that showed that immune checkpoint inhibitors can be combined with TACE. A similar study here with in terms of radiation therapy. There's a study from China with sintilimab, a PD-1 inhibitor, small numbers, but as you can see, this was SBRT in combination with checkpoint inhibitors. That is patients who received sintilimab, that is 200 milligrams every 3 weeks along with SBRT. Really combinations with checkpoint inhibitors and radiation are pretty well tolerated. Very nice response. So I think this is sort of where we are going in HCC. The future is one for immune therapy, future is immunotherapy combinations, and we just have to learn to how to integrate small molecule inhibitors along with checkpoint inhibitors. I'm going to jump gears with, given that time is limited, to biliary tract cancer. And so the point to note is biliary tract cancer is, of course, not one entity. It represents three different cancers. Unfortunately, intrahepatic cholangiocarcinoma is a disease that is rapidly increasing. That is the red line. And that, we believe, is because of obesity and metabolic syndrome and other also NASH-related diseases, lifestyle diseases. And that's led to increasing patients being diagnosed with this disease all over the world. This is treatment patterns. A fellow of mine presented this at ASCO this year, that despite the advantages in novel therapies in biliary tract cancer, most patients, only 85% of patients in the community in the US actually get treated, 46% get second line, and 17% get third line. And the average duration of this treatment is pretty short, it's 3 to 4 months. So this is an area that remains one of great unmet need. I'm going to jump into areas that are being investigated, that is novel cytotoxics, molecular targeted therapies, and immunotherapies. Our standards are still based on the study done a decade ago with GemCis, which resulted in a survival of 11.7 months as compared with 8 months with gemcitabine. At our own institution, Dr. Shroff led the study with GemCis and nab-paclitaxel, which resulted in a progression-free survival of 11 months and a median overall survival of 19 months. So it's a small study of 60 patients at Anderson and Mayo, but certainly showed that this disease is chemosensitive, and sometimes they can handle a good amount of chemotherapy with good responses. This has led to a phase 3 trial, the first phase 3 really of chemotherapy conducted in the US. And so this trial is completed, and we hope to get the signal by next year. In the second line setting, FOLFOX is based on the ABC06 trial with the PFS of 4 months and an overall survival of 6 months. So although it's a standard, it's not a great standard. And earlier last year, this was the nifty study from my friend Dr. Yu from South Korea, where they looked at NALIRI, nano-liposomal irinotecan with 5-FU, really like a FOLFIRI regimen, which achieved a progression-free survival of 7.1 months versus 1.4 months of that with 5-FU. So this regimen is now an NCCN recognized regimen in the second line setting. But clearly what has changed in biliary tract cancer, which touches my heart, is the fact that next generation sequencing has identified a large number of actionable mutations. So this was one of our first studies now almost 8 years ago of 400 patients, which showed that intrahepatic cholangiocarcinoma, that's ICCA, extrahepatic and gallbladder cancer, intrahepatic particularly, is enriched with a large number of actionable mutations, such as the IDH pathway, FGFR pathway, and HER2, almost 40% of patients. The first agent to be investigated in this space was ivosidenib versus placebo in the second line setting for IDH1 R132 mutation in intrahepatic cholangio. Progression-free survival was a primary endpoint. You may think this progression-free survival is not striking, 2.7 months versus 1.4 months with placebo. However, there's a tail in the curve. So there's, about 20% of patients have disease control at the end of 1 year. And this is what eventually led to the study drug being approved. Overall survival benefit is hard to elicit in a crossover study, which this was. However, by using statistical modeling, such as the one shown here with rank preserving structure failure time, they showed that the overall survival improved from almost 5 months, which is the green line, as compared with 10 months with ivosidenib versus placebo. FGFR signaling is an area that I've worked on for many years. It's one of the most commonly mutated pathways in oncology. And FGFR aberrations in cholangio occur in younger patients, chiefly in women. And this led to our phase 2 study design of the small molecule inhibitor infigratinib for patients who had progressed on GemCis and had FGFR2 fusions. And these patients, we see a response rate of 34%, objective response, best overall confirmed and unconfirmed was 42%, disease control rate of 88%. And for the first time in biliary tract cancer, we started seeing striking waterfall plots like this one with infigratinib, where almost over 85% of patients had some degree of disease control. Now, as you know, there's other agents in this space. Pemigatinib, an excellent agent, also approved with infigratinib. Furibatinib study was presented at ASCO this year by my friend Dr. Goyal, and the Derazantinib study also is completed. It's sort of a uniform theme here: 7 to 8 months of progression-free survival, 12 to 20 months of overall survival, depending on the stage at which these drugs are used. I'm going to jump quickly into other mutational targets. This is BRAF V600E mutated cholangio. So this is a study done by at Anderson by my colleague Dr. Subia, where patients got BRAF plus MEK inhibitor combination with almost with 40% response rate, responses lasting as long as 8 months. This has led to a agnostic approval by FDA actually last week for BRAF V600E. A study that we did in trastuzumab and pertuzumab with HER2 amplified cholangio, which is 23% response rates. And these were deep sustained responses. As you may have seen in ASCO this year, the Destiny trial with ADC, with trastuzumab deruxtecan, had a very impressive 50% response rate in biliary tract cancer. So this is a ADC, a bispecific ADC, zanidatamab. This is a phase 1 data completed at our center. 40% response rate, disease control of 65%. So really a very effective drug. It led to a pivotal phase 2 study designed by my colleague, Dr. Pant, and the study is completed. Hopefully we get another HER2 drug approved in the second line space in biliary tract cancer. DNA damage or genetic alterations are quite common, including BRCA, ATM, ATR, RAD51, and so on. By common, I want to say around 15 to 20% of biliary tract cancer, more in gallbladder cancer, a disease that is well known in India. And hopefully that will lead to other DNA repair inhibitors such as olaparib. I'm going to jump in the last part of my talk with immunotherapy. Biliary tract cancers are generally a low immune mutation burden tumor. TMB is about intermediate to high TMB is 5 to 7%. This is the second line pembro experience, which shows that the activity was modest, about 6% response rate, but it was not the same as other cancers like pancreas, for instance, where it's even lower. So these patients, a small subset of these patients do respond. And this year, based on the Topaz-1 study, durvalumab was approved in combination with Gemcis. This study was a phase 3 study of Gemcis plus or minus durva, with overall survival as a primary endpoint. And the median survival did improve. As you see, the median survival the improvement was modest from 11.5 to 12.8 months. But again, there's a good tail in the curve, where 10% of patients with Gemcis had disease control, whereas 24% of patients had disease control at the end of 2 years. So they got Gemcis and durva for 6 months, and then durva as a maintenance therapy thereafter, versus placebo at the end of 6 months. And clearly at 6 months, these curves separate. There seems to be no great relation in the Gemcis durva study in terms of PD-L1 status, but the box I've highlighted is that the region of the world does seem to matter. Asian patients, that is, this study was also open in India. The Asian patients seem to benefit more with durva than the Western patients. Clearly, there's a difference there. We don't know whether this is guided by Hep B prevalence in East Asia. No great correlation with PD-L1 status in that analysis. So this is my last slide. I mean, I've been treating cholangio and biliary tract cancer for 15 years, and this is really an exciting time. You know, there was no drug approved before 2020, and we have 3 approvals now. You know, infigratinib, pemigatinib, ivosidenib, hopefully furibatinib this year, and durvalumab this year. Several NCCN designation. The advent of molecular profiling targeted therapy has led to this sea change. IDH1, FGFR, HER2, several promising areas. Immunotherapy for hepatobiliary cancers is promising, but we do need predictive markers. Although they're not lacking, we do have some clinical phenotype. And certainly, as far as biliary tract cancer goes, it's a model for precision medicine in GI tract cancers. So thank you again, Santosh and Vishwanath, for inviting me to share some of these thoughts on these two cancers.
Um, Thank you so much, Dr. Javle. It was a wonderful. Dr. Annie Jacob, please to share her slides.
Here I'm presenting a case capsule of HCC, 62-year-old female who is a non-case of hypertension. Her presenting symptoms were severe incapacitating pruritus and weight loss over 1 year. She underwent CT abdomen and pelvis elsewhere 1 year prior to presentation to Apollo, which showed multiple liver lesion spanning both lobes of liver, ranging in size from 4 centimeter to 13 centimeter, which was biopsied and diagnosed as hepatic adenomas, and she was treated symptomatically without any benefit. She then presented to Apollo after 1 year of symptomatic treatment. She was worked up and AFP showed 4.76 nanogram per ml, but PIPCA2 was elevated and more than 22,000 millianson units per ml. So the initial biopsy was reviewed and IHC was suggestive of hepatocellular carcinoma. PET-CT was done, which showed bilateral FD-Javle liver lesions large as 13.9 into 9.4 centimeter in left lobe. There was no evidence of extrahepatic disease or metastasis. Serology was negative for hepatitis B and C. After workup, she was staged as BCLC intermediate stage hepatocellular carcinoma, childhood egg. She had intense pruritus and extremely poor quality of life, so she was offered live donor liver transplant. Family was told that liver transplant would be offered only if they accepted an estimated post-op survival of about 1 year, but she will be free of pruritus. She underwent live donor liver transplant on 28/6/2021. She did well immediate after transplant and she was on follow-up with the transplant team. In January 2022, she presented back with the neck pain. PET-CT on 28/1/2022 showed 0.8 centimeter left lower lobe lung lesion without PET uptake, but hypometabolic C7L4 vertebral body lesion suggestive of skeletal metastasis. She received radiation therapy to the C7 symptomatic lesion, SBRT to a dose of 24 gray in 2 fractions in the early February. FP was within normal limits at that point, and PIPCA was 1161. She was started on oral lenvatinib in February 2022 at a dose of 8 mg per day. PET-CT in the reassessment PET-CT in April 2022 showed interval development of few new hypermetabolic skeletal lesions, including left lobar femur, T2 transverse process, spinous process of L4, and a non-hypermetabolic hypodense nodule in posterior aspect of liver. And there was an anterior abdominal wall nodule, which was suggestive of post-progressive disease. AFP was within normal limits and PICA was elevated than the previous value. It was decided that she was continued on increased dose of oral lenva, 8 mg, 12 mg alternating days. She is also on bone anti-resorptive agent injection denosumab 2 monthly. Here the concern is immunotherapy indicated in this patient who is on post-transplant immunosuppressive agents like tacrolimus, everolimus? What are the chances of graft rejection and poor response to immunotherapy?
So Dr. Javle, we request your expert comments on this.
Yeah. Thank you. Well, Dr. Jacob very nicely presented. I want to first, I would love to see what the scans were when she had these adenomas, so to say, for a year before diagnosis, right? I mean, to diagnose HCC, you need a liver protocol scan, and that scan looks at what are the radiological features that are typical for HCC, you'll have a rapid arterial flush and a
Yes.
portal venous washout, right? So
Yes.
you'll have a flush washout. I mean, if that is present, it is very unlikely that it's going to be an adenoma. It's going to be an HCC. So I don't know what happened,
Yes.
but a lot of time has gone by.
Mhm.
Now, when she presented with this large lesions, interestingly, like you said, her bilirubin was fine, but she had terrible pruritus, right? She was child Pu A.
Yes, sir.
So one of the things that I just want to make a point about management of pruritus in the clinic. It's an extremely vexing and a troublesome symptom. What we sometimes find is, working with dermatologists, you sometimes use bile acid binding resins, like ursodeoxycholic acid, cholestyramine, things that can bind bile acids, help itching. Sometimes steroids, even like PUVA therapy, like they use in psoriasis. So there are methods to sort of treat itching, which is of course a horrible symptom. I mean, itching sounds not that consequential, but if you're itching like crazy day in and day out, it can drive you absolutely crazy. So I wonder, Vishwanath, if you can go back to that scan,
Sure, sir.
the PET scan and the CT scan. Yeah. So let me ask you, Dr. Jacob, does this fit into like the Milan criteria or the UCSF
No, sir.
criteria for
No, sir.
transplant, right? So
No.
as a bright young oncologist, you know that these criteria were developed, oncologists in the making, these criteria were developed so as to identify the best candidates for transplantation. Before Mazzaferro, that editorial in NEJM, you know, before he had a program for transplantation. UNOS had contraindicated liver transplantation for HCC. It was the Milan criteria which established that first, patients who have an indolent or a reasonable disease trajectory should be considered for transplant because otherwise risks are too high. The organs there's a worldwide shortage, right, of donor organs, and living donor transplantation is not without risks, especially for the donor. So I think in this case, well, it was done for the hope of benefiting this patient, and this transplantation was done. What did you say in June of 2022, something like that, and then you
21,
had
sir. Yeah.
21, and then you had a recurrence in the 21 and recurrence in April, right? So you had about 7-8 months, and there was this multiple bony recurrence, which kind of gives you a picture of what happens for aggressive large tumors. So I think, hindsight is 2020. Nobody's going to blame anybody for anything. But would there be a possibility of downstaging this patient with neoadjuvant therapy, like lenvatinib or even immunotherapy, to try to shrink this tumor before going to a transplantation? So in this case, that we didn't do that, but and this patient had this bony recurrence and all of that, all those things. Had lenvatinib, the lenvatinib has not worked. Now the consideration is, where do you go second line? So I think we can learn a little bit from management history in the past, and perhaps, might have made some different decisions upfront. Now, let me just also make the point, if the patient is on, say, atezo and bev, can you actually do a liver transplant? Can you do a transplant for somebody who is getting immunotherapy? And the textbook answer is no, because, there's a high risk of transplant rejection. But there are increasing bodies of data, particularly from Mount Sinai in New York and now some other centers, which show that for patients who have had a neoadjuvant or, immunotherapy before transplant, if you stop it within three half-lives, which is like 2 months, or even in some cases, people who have had it before, but give them strong immunosuppression post-transplant, which includes steroids, which includes, the immune suppressants that you have mentioned, it can be done. Now, in this case, after Lenvatinib, now this has already happened. The transplant's already taken place. So what more can we do? There are, as you know, there aren't great data to show that regorafenib, cabozantinib, ramucirumab will be effective after, say, lenvatinib. However, there are data to this effect with sorafenib, right? These drugs were approved after sorafenib, and sorafenib and lenvatinib are not that dissimilar, right? So I would recommend we first consider one of those agents, one of, either cabo or regorafenib. Ramucirumab is currently approved for AFP more than 400, so we don't have that. But certainly those agents can be considered before considering immunotherapy. What is the likelihood of those agents working? I mean, there's good body of data with, with their approval, right? About 20% response rates in most of them, PFS of about, 4 to 6 months. So it's not nothing. In terms of giving immunotherapy with checkpoint inhibitors at this point, well, I mean, the studies that have been done so far, there's a Chinese study, and there's about 30% risk of graft rejection. So there's an ongoing trial that we and other centers have where people are offered immunotherapy after exhausting these options under high dose steroid cover, high dose of immune suppressant cover. It seems like you can do it, but there's certainly a risk. And I would not go there right now while you have a few other options.
Dr. Javle, excellent points. Dr. Vishwanath here. So there is also some growing data that CTLA-4 inhibitors are better than PD-1
Yes.
and PD-L1 blockers in this kind of a situation. What's your thought on that aspect?
Well, I mean, you're right. There are some data in that regard, but I think it really depends on it's more depend on the etiology of the disease and especially for non-viral hepatitis related HCC. There's some thought that addition of CTLA-4 may be of value over, but it's still not really a proven point. And I mean, Nivo NEP would be something to consider in the second line setting. It is probably better, perhaps better than Pembro or Nivo second line single agent. But I think regardless of that, I would first try the non-IO options, Vishwanath.
Sure. And also there is, I was just going through the review of literature, and it also says that modifying the doses of mTOR inhibitors may also help, like you mentioned.
Absolutely. So mTOR inhibitors, high dose steroids, cyclosporine combinations. So there are now regimens that are developed for patients who have, say, underlying autoimmune disease and get immune therapy, right? So those are the kind of regimens with like triple immune suppression therapy, immunosuppressive therapy.
And when we are giving high dose steroids, the lymphocytes going to go. The lymphocytes are going to go for a toss. So how will immunotherapy work?
Well, interestingly, Vishwanath, for people who have had, for instance, autoimmune hepatitis and HCC, or in biliary cancer like primary sclerosing cholangitis and cholangiocarcinoma, it doesn't really impact that much in terms of the outcome of immunotherapy. So you would say intuitively that if you're giving immunosuppressants, how will immunotherapy work? Well, actually, there are many mechanisms by which immunotherapy works, right? It's not just CD8. You have decrease in Tregs, decrease in MDSCs. So not all of that is affected by the interferon gamma signature. Not all of that is affected by steroids.
Perfect. Thank you so much. So thank you, Dr. Annett, for that interesting case. Shifting gears to cholangiocarcinoma.
Thank you. Good job.
So shifting gears to cholangiocarcinoma, now we have Dr. Chinmay Agarwal from MS Ramaya Medical College and Hospitals, and she'll be presenting on metastatic cholangiocarcinoma. Over to you, Dr. Chinmay.
Good evening, everyone. Myself, Dr. Sandeep Bhaskar, SR Medical Oncology from JIPMER. Today, I am presenting case scenario of metastatic CA gallbladder. A 38-year-old female with no known comorbidities presented with us with intermittent abdomen pain since last 1 year and history of vomiting and yellowish discoloration of urine since last 15 days. On examination, her ECOG performance status is 1 and icterus is present with left supraclavicular lymph node of size 2 by 1 centimeter palpable and per abdomen no mass palpable. On evolution, her LFT is deranged, bilirubin and ASTLC are increased and CA 19.9 is more than 2000. On further evolution, CCT triple phase liver showing intraluminal growth in GB that involving liver parenchyma at hilar region with bilobar IHBRT and non-regional lymph node peripancreatic periportal lymph node also involved. On further evolution, FNAC done from left supraclavicular lymph node that is showing metastatic adenocarcinoma. And after that, ERCP stenting done. After ERCP stenting, bilirubin and AST-ALT comes to normal. Final diagnosis, 38-year-old female with no known comorbidities with ECOG of 1, case of metastatic adenocarcinoma gallbladder, stage 4, post ERCP stenting. So point of discussion is whether biopsy is required from local side for NGS for molecular panel and palliative chemo, which regimen to be given between GEM-CIS, GEMOX, or either we can use modified FOLFIRINOX as afferent setting and role of targeted immunotherapy in this case.
Thank you, Sandeep. Vishwanath, would you mind going back to that scan?
Yeah.
Yeah. So Sandeep, as you mentioned, this is a very aggressive disease, which is involving the hilum, right? You have biliary ductal dilation. You have the portal vein, which is right there. So this patient, the cause of mortality here is going to be liver failure, is going to be portal vein obstruction.
Yes, sir.
You know, the traditional dictum was gallbladder cancer is that gallbladder cancer with jaundice is bad news because gallbladder cancer, by the time it causes jaundice, it has spread along the gastrohepatic ligament to then cause biliary ductal obstruction.
Yes, sir.
So good job there. You have palliated her with palliated this patient with ERCP. Unfortunately, this is not going to be long lasting. So we have to treat soon. So the first question is, do we need to biopsy? I would say yes. Now, gallbladder cancer is a disease that tends to migrate along needle tract insertion sites.
Yes, sir.
So you have to be very careful with the radiologist who can biopsy the lesion going through the normal liver and keep a tract of the needle tract that is deep, not directly into the tumor, but distant through the liver, so that there's less risk of seeding through the abdominal wall. Once you do get that biopsy, now if the tumor is restricted just to the gallbladder, I can't tell very much in this scan, but if there is no involvement of the liver, then biopsy of the gallbladder is going to be difficult.
Yes, sir.
I can't imagine that there's no lymph node involvement. You know, with this large tumor, if you dig deep into those scans, then you're going to find some lymphatic involvement. We can hopefully biopsy the nodes.
Yes.
With percutaneous or endoscopic ultrasound guided biopsy. Now, is there a role for NGS? there's absolutely a role for NGS. 15% of gallbladder cancer have HER2 amplification. Now, it's a difficult disease, but I'd like to say if we don't look, we are not going to find, especially for something like HER2. You can detect that with immunohistochemistry. You can detect it with NGS with HER2 amplification or FISH, or even a liquid biopsy. So I would consider that in terms of molecular diagnostics. But in terms of biopsy, I think you'll have to discuss with a good interventional radiologist to see in terms of biopsying either the nodes or hepatic involvement, not directly puncturing the gallbladder wall, but look at those other sites for potential avenues for getting the histological diagnosis. Can we go further into the questions?
Yes, sir.
The other point I wanted to make, Sandeep, is that there is this entity called small cell carcinoma of the gallbladder, which occurs in 4 or 5% of the time of all gallbladder cancers. And the treatment for the small cell is not gemcis; it is sort of like small cell. So with etoposide and carbo, etoposide and cis, and increasingly now atezo, given as maintenance therapy, like used for small cell of lung cancer. So biopsy would be of value. What would be the chemo of choice, gemcis or gemox? I think gemox is a regimen more commonly used in India than what we use.
Yes,
If this is something you're comfortable with, you should do it. Now, as you know, Atul Sharma from Delhi did a study of gemcis versus gemox. I think it was in Annals of Oncology or some journal. There was no difference between the two. So either of those. In terms of FOLFIRINOX,
yes,
I don't particularly use that because there was a study from France by the Prodige group, the same group that did the FOLFIRINOX pancreas study, with gemcis versus FOLFIRINOX. Actually, the survival was not improved. It was a little worse with FOLFIRINOX, and the toxicity was higher. So it's not a regimen for some strange reason. It doesn't work that well in biliary, whereas intuitively you'll think it's a more potent regimen. It isn't.
But sir, in China, one study done, sir, between FOLFIRINOX and gemox, that's showing significant increase in median OS and PFS, sir.
Yeah,
And better disease control rate, around 76% versus 47%, sir.
yeah. So Sandeep, I'm not familiar with that study, but the one that I'm familiar with is the Prodige study from France. That's the group that really developed the gemox and FOLFIRINOX, both the regimens. They actually found worse survival. So based on that, we don't use FOLFIRINOX in this setting.
Okay.
In my view, it adds to toxicity. Now I'll have to look deep into this China study and see, but
yes. And between sir gemcis and gemox also, that gemox having sir more grade 3-4 diarrhea and peripheral neuropathy compared to gemcis, and that survival is comparative same, sir. So which regimen we should use, sir?
So we don't use gemox in our practice. We use gemcis because cis is used in small doses, 25 milligram per meter square,
Yes,
not a big dose.
And that Indian study done, sir, that used oxaliplatin also 80 milligram per meter square only, that modified gemox.
Right.
Yes. Sir.
So we use gemox only if people have renal insufficiency, But yes. I think it's a reasonable option, and if that's a more commonly used regimen in India, you certainly have more experience with it, and there's no discounting that. I think both can be used. Now, in terms of targeted immunotherapy and targeted therapy, as we just discussed, durvalumab was approved, right? Not approved. It will be
yes,
approved.
Sir. Topaz study, sir. Yes.
Topaz one study,
yes,
right?
Yes.
So it's reasonable to consider. In that study, the gallbladder cancer, it was not stratified, for
yes,
gallbladder cancer.
All three are there, sir. Biliary tract.
All three are there, and
yes.
I don't know if I can share my screen again. I'll show you the gallbladder. No, I can't. But the gallbladder cancer patients in that forest plot didn't derive that much benefit, although it was a small number. The intrahepatic and extrahepatic the survival was more in terms of, and it's an expensive drug. So uh, especially when insurance coverage and all is limited, I think it's reasonable, but I wouldn't push for it. I mean, for durvalumab necessarily. In terms of targeted therapy, I think we'll have to wait for NGS, and it's very reasonable to consider the ones that you see in gallbladder are HER2 amplification, EGFR amplification is also not uncommon. So, and you do see these occasional patients with high TMB or for which you might consider.
But TMB is less than 1% in this biliary type.
Yeah, so it's the high MSI is 1%,
Yes,
and
sir.
intermediate or high TMB. So that is TMB that is 10. Is Keytruda is approved in the US for TMB of 10.
Yes.
So that is 2 to 5% who have a TMB of 10 without MSI.
Yes.
Yeah.
Thank you, Dr. Sandeep.
Sir, one more doubt, sir. Sir, if biopsy not possible, further what will be the management, sir? Like this patient, one more patient we have. We tried 2-3 times endoscopic biopsy, but we are not able to get, sir. So if biopsy not possible, then what to do, sir?
I'm just thinking why. Yeah, I'm not
Because
sure.
FNAC is there, sir, that metastatic adenocarcinoma from left supraclavicular lymph node.
Yeah, so actually, Sandeep, the left supraclavicular lymph node would be a good place to remove, right? You can remove the node and do an NGS rather than go for the gallbladder.
Yes, sir.
Sure.
Yes, sir.
You can also get a core biopsy from there.
Okay, sir.
Yeah.
Thank you, Dr. Sandeep. That was an interesting case. Just one last question, Dr. Javle. As far as this Dr. Rachna Shroff's GAP regimen, which she presented, the phase 2 trial, there was almost a 20% chances of the unresectable disease becoming resectable. So what are your
Yes.
thoughts on that, Dr. Javle?
So that is a very good, regimen for, I mean, I'm biased. We did the study and we found some patients who were unresectable who got resected. Particularly for patients who are what we consider, there's no definition like borderline resectable in cholangio. But if we have made up one, like multifocal disease in one lobe of the liver, or disease that is in the liver with regional nodes. So for patients who you and the surgeons think is a high risk for recurrence, I think it's certainly a consideration, certainly worth considering.
Thank you. So thank you, Dr. Sandeep Bhaskar, for the nice case presentation and interesting questions as well. And let's move on to the last case. And I will try to share the slides on behalf of Dr. Chinmay Agarwal. And she's from MS Ramaya Hospitals in Bangalore. Dr. Chinmay, do you want to start presenting? And I can share the slides.
Yes, sir.
Okay, perfect. You can start.
Good evening, everyone. I'll be presenting a case on the case capsule on cholangiocarcinoma. So we had a 56 years old gentleman who presented to our OPD with the complaints of abdominal pain and loss of appetite from past 2 months. This was back in September 2020. He also was a known case of type 2 diabetes mellitus and the seizure disorders. So for the evaluation of the abdominal pain, he underwent the ultrasonography, which showed the 5 into 4 centimeter hepatic lesion in the left lobe of the liver. We did the cytology from the liver as well, which was suggestive of adenocarcinoma. Along with that, the routine workup, blood workup, which included the CBC and the biochemistry, were within normal limit. On the further evaluation, we did the PET scan, which showed a 4 into 3 centimeter lesion in the left lobe of the liver, infiltrating the intrahepatic left lobe biliary duct, intrahepatic left portal vein, and which was suggestive of intrahepatic cholangiocarcinoma. Along with that, the findings were that the patient had bilateral lung nodules, which did not had a SUV uptake, and the size were 4 mm. And periportal lymphadenopathy was there. Along with that, the left para-aortic lymph node was present, which was of 3 into 2 centimeter and a SUV uptake of 3. Along with that, we did the tumor marker CA19.9, which was 124. So the main dilemma was how to stage that patient. So whether to take these lung nodules as a metastatic or para-aortic also as a metastatic. So we clinically staged the patient as clinically T2N1 M1. The next question which came to our thing was whether to treat with a curative or the palliative intent. However, since we took a surgical oncology opinion and the tumor was unresectable, so and as we know that the mainstay of the treatment will be surgery followed by the adjuvant treatments in the local setting. So we took it as a palliative intent and started with the GEMOX chemotherapy. Yes, the treatment of choice is gemcitabine and cisplatin. However, the cisplatin requires a longer stay and more finances, so we went ahead with the GEMOX chemotherapy. Post 3 cycles of chemotherapy, we did the response assessment with CA 19.9, which came down to 82, and along with the PET scan, which more or less showed the stable disease. The SUV was unchanged for the liver lesion. The lung nodules were same as 4 mm. However, the lymphadenopathy had no SUV, but the size was still unchanged. So we labeled it as a stable disease and continued with the 3 more cycles of GEMOX chemotherapy. Along with that, in the month of January, we also did a NGS testing, which showed a ATM and STK11 mutation. Our NGS included the 190 panels, and especially the ones whom we can target IDH1, FGFR2, BRAF, NTRK. But to our bad luck, we didn't have any mutation found, so that any targeted therapies we could have offered. So hence we completed the 6 cycles of chemotherapy and kept the patient on observation. On subsequent follow-up during May to 2021, we did the repeat scanning, which showed a considerably less size of the liver lesion, which was 2 into 3 centimeter, and the CA19 was 0.9 was within the normal range. Then another scan was done in August, which showed the CA 19.9 of 78, and along with the ultrasound of imaging of showing 4 into 3 centimeter left liver lesion. Then, since there was a clinically as well as radiological and biochemical progression, we started the patient on oral tap capecitabine. Just after starting capecitabine, post 3 days, the patient developed ECG changes, which were the ST elevation in the V4, V5, V6, and we labeled it as capecitabine-induced vasospasm. Hence, we had to change the therapy. So the next line we went on was the irinotecan-based therapy. So the patient received single-agent irinotecan for 6 cycles. And thereafter, on the subsequent follow-up, there was a rise in the CA 19.9, along with the clinical progression, like the patient had the pain in the abdomen, poor day-to-day clinical day-to-day life activities. However, the performance status of the patient was good. We gave the localized EBRT for the palliative symptoms, 30 grade 10 fraction to the local site. And after completion of that, the patient currently has a good performance status and has an intermittent abdominal pain. The question comes now, how to proceed next for this patient? What other lines of therapy we can offer to this patient?
Great. Thank you very much, Inmai. Very nice. Can you please go back a little bit on, I want to see your PET scan here. The first PET scan, right. So this lesion has this mass in the left lobe of the liver. Interestingly, as you mentioned, there was a history of fatty liver, right? So this was a patient who had some underlying liver disease. The mass shows that you have FDG avid uptake. These lung nodules, were they positive on PET or they were not?
They did not had any SUV uptake on PET.
Yeah. But there was positive nodes. So you said you have periportal and para-aortic nodes. So to my knowledge, I think when you have left-sided tumor, the regional lymph nodes are hilar and gastrohepatic ligament nodes. Periaortic, I think, is a distant node, maybe an M1 disease. But regardless, there was suspicion, right, that there was M1 disease in the lung. So for any metastatic disease, in general, when patients who have resection for intrahepatic cholangio, ostensibly they are cured, but the reality is only 30% of people are cured. the risk of recurrence is very high. And in fact, the risk of recurrence is, about 50% or higher in the first year after resection. So especially for this patient, neoadjuvant therapy makes perfect sense. So next slide, please. So therefore, you went ahead and, did this neoadjuvant GEMOX, which led to stable disease. So I'm just wondering, at some point, next slide, please. And next, I'm just wondering, when was the surgical evaluation for resection? When was that conducted?
So we did at the baseline. Thereafter, since the patient had not very good response and that there was a persistent periportal and the left para-aortic lymph node, so the surgical resection was not feasible in this patient.
Yeah, and I think it's reasonable. I mean, as far as lung metastases are concerned, it's a similar situation, Dr. Agarwal, to colon cancer with oligometastatic lung disease. These patients don't die of their lung disease, right? Even if it is a small, low volume disease. So I wouldn't say we ignore it, but metastatic disease to the peritoneum or liver has certainly a different implication from low volume lung disease. So we would consider surgical resection in somebody who has low volume lung disease. This patient also has para-aortic nodes. So I think surgery is certainly, that complicates the matter. Now, in terms of radiation therapy, next slide. I just want to go to the dose of radiation. So what we found was that the dose of radiation does impact on overall survival. And of course, radiation is expensive. It can have toxicity, not easily available. But there was an article in JCO published by a group, our group, Dr. Tao, TAO is the first author. You might look it up, Chinmay. And it was the dose of, because unlike liver cancer, intrahepatic cholangiocarcinoma, underlying liver function is actually fairly reasonable. So these patients can actually handle pretty high doses of radiation, and they can have palliative benefit that lasts for a long time. So in this case, we have given radiation, and it did seem to control for a little bit. But you feel like this intermittent abdominal pain is because of progressive disease? Is that what the current thinking is?
Yes, sir. The main complaint is the patient is not comfortable having abdominal pain. We do have to give little opioids, like he's on morphine, and along
So
with
what is
that,
the scan? The scan is showing progression.
we haven't done any recent scan, so we were planning on that doing like on the next follow-up of the patient.
Right. I mean, you want to see if this is pain is coming from peritoneal disease, or is it coming from progressive liver disease, as far as what the cause is. Now, in terms of treatment option, there's very limited standard option. You have already given GEMOX, you're also given FOLFIRI. So, I don't think there's great value in giving FOLFOX for somebody who's already got, FOLFIRI and GEMOX and capecitabine, and plus they had vasospasm, as you mentioned. There's really no standard therapy at this point in terms of chemo. In terms of ATM mutation, DNA repair inhibitors are of value, like olaparib, or a group of drugs called as ATR inhibitors. But olaparib will not be effective if the tumor is platinum resistant. So there's cross resistance between the two. So the only other option that you haven't tried yet is immunotherapy. And immunotherapy may be of some value, but as you saw, the response rate is less than 10% as a single agent, Nivo and Pembro, and these are not inexpensive. These are pretty expensive therapies.
Yes,
so I would probably start, Dr. Agarwal, by getting a scan, seeing where this pain is coming from, and trying to dive deep over there and see if there's some way to treat that. You say the patient's performance status is good. The only other option that, in terms of chemo that we have used for people who have had a reasonable response to GemOx before and then have progressed is use another gemcitabine based combination like gemabraxine. And this comes from pancreas data. When we didn't have a lot of options, we used different gem combinations, right? So that I'm not terribly optimistic. It is something that has been done. In Europe, there was a study called REACH-IN study where they used regorafenib for patients who have received prior chemotherapy. Again, it's mostly a disease stabilizing drug. So I don't know that it's going to be of great value here. So we may be looking at, unfortunately, supportive care. But I mean, based on the scans you show me, I don't see where the progressive disease is. So let's take a look at that.
Sure, sir.
Can we use triple regime, sir? Gem, cis, and nab-pacli combination.
So Sandeep, after she has progressed on GemCis, I don't know it's worth doing GemOx. I don't know it's worth putting her through that toxicity.
Yeah. So,
Yeah.
Dr. Javle, a couple of questions. We saw some growing interest with dostarlimab in MSI high patients. So, what is your experience with this particular drug in cholangio and other hepatobiliary malignancies?
So, I mean, the drug that has received a lot of attention, as you saw, Vishwanath, when you were at ASCO.
Mm-hmm.
I think some of that attention was deserved, and some of it, I think, was overhyped. I mean, these patients had MSI high, low burden rectal cancer, right? So these patients are going to respond to immunotherapy no matter what. And we are all noticing that some patients who have MSI high, cholangio, I mean, it's not a common situation. I have probably about 8 or 10 people in my practice. But those who have MSI high cholangio, they don't have a history like Dr. Agarwal described. They all respond. They have long duration of responses. So I think, I mean, is dostarlimab significantly better than pembro and nivo for MSI high? I don't know that yet. I mean, it's a low burden, early stage rectal cancer, and patients had a complete response. I wouldn't be surprised if you see that with other checkpoint inhibitors as well. So I was amazed. This was the take-home point from ASCO that dostarlimab for MSI high early stage rectal cancer. I'm a little bit more cynical about that information.
So we're all getting a flurry of WhatsApp messages after that.
Yeah, all of my patients want dostarlimab, but I'm not sure that is, that is a great paradigm shifting finding.
And also, one of the interesting aspects of this ASCO education session, so over a period of time, they're also thinking about BRCA1 and BRCA2 becoming like tumor agnostic markers. So what is your thought on that?
Well, I mean, definitely for BRCA1 and BRCA2, even diseases like pancreas cancer, right, which is KRAS mutated, very aggressive, now it's approved. So I would think of very good reason why it should be agnostic, tumor agnostic approval. But these drugs, unfortunately, don't lead to tremendous responses. Like partial response rate is not that high. It's mostly stable disease.
There's one question before we wind up: role of immunotherapy in hepatocellular carcinoma for rarer entities. This is a question in the chat box.
So, like you're talking about, like fibrolamellar cancer, that sort of thing. Yeah, we don't really have. Yeah, actually, those cancers, they respond better to chemotherapy. I think they may respond to immuno as well, because we used to use drugs like interferon, alpha interferon, things like that for fibrolamellar cancer. So there's there are ongoing studies of nivo in combination with chemo, because fibrolamellar is a chemo responsive tumor.
So we all, due to logistic issues, sometimes we have patients initially with advanced hepatocellular carcinoma on TKIs like sorafenib or lenvatinib, and then they have this insurance approval, and then they want to go as a second line for atezolizumab plus bevacizumab. I know there is no approval, there's no data for second line, but have you used it in second line, extrapolating it from first line?
Second line atezo and bev.
Yes.
I mean, I think you can make a rationale for it. Certainly you can. It's not, since they're approved now. I mean, to be honest, I haven't used sorafenib for a long time. We use lenvatinib. But if you have used sorafenib first line, there are many options. Besides the TKIs, you have IO of various kinds, IPI and Nivo, Pembro. I suppose you can use atezo and bev. I mean, although I don't see why not.
Sure.
Yeah. What is your response experience been with IO for HCC in India?
So fantastic. In fact, I've had 5 patients with atezo plus bev. In fact, my oldest patient is 86-year-old and he's 2 years down the line. He's in CR.
Wonderful.
There's
hepatitis related or?
Pardon me?
Hep B related or Hep C related or?
Well, in fact, after seeing your interest, it was probably NASH related. But when I saw your slide that they don't do that well with PD-1 blockers, that was quite interesting, that slide.
Yeah. I mean, the hazard ratio is like 0.8. It's not like, so there's some benefit, but it's lower.
Yeah. Thank you, Dr. Chinmay, for that interesting case. And thank you, Dr. Javle, for that exhaustive and very comprehensive discussion. In fact, Meet the Professor session was fantastic. And I think our postgraduates really learned a lot. In fact, we learned a lot from today's webinar. And I'm really grateful to you for actually making time out of your busy schedule. And thank you so much once again. And we would also like to thank our sponsors once again for the educational grant. It's actually a not-for-profit foundation. We use it only for paying the honorariums and making the foundation more stronger and stronger as far as the educational perspective is concerned. And thank you, Cipla Oncology, Reliance, as well as Fresenius Kabi. Thank you once again, sir. And we look forward to having you for many more sessions in the future.
Thank you very much. And congratulations to you and Santosh for doing this, because it's such a great exposure for young people there. And I particularly enjoyed learning from all of you. Thank you.
Thank you so much, sir. Thank you.
Thank you.
Bye-bye.
Bye.